Good evening, everybody. I am Dr. Kinan, and my pleasure is to be your assistant in this class for CTC exam. You may be heard that CTC exam is impossible. It is very hard to pass, but believe me, CTC exam just need to know how to pass it. My job here is to help you to make this CTC exam very easy. For CTC, you have to know every information about general medicine, about every disease. I will help you to gather every information for every disease from this book and from this book, and organize this information in this class to make the exam very easy. You just maybe know some Turkish language a little bit. You have to know it because it will be some slices in Turkish language. My plan here is to give you general medicine, general information about diseases. Then I will give you some slices in Turkish language to know the Turkish medical words and to know how to focus on the important information about CTC. Now, Turkish doctors in this exam love to focus about some part, some section, so you may be surprised that in the exam some parts came many questions about some parts. So you have to study everything, you have to know everything about this exam. In CTC exam, you know, we have 120 questions, 40 about internal medicine, 30 about pediatrics, 30 about surgery, and 20 about kadın doğum hastalıkları, gynecology and obstetrics. So, my advice here in this exam to start in surgery questions, because I noticed that surgery questions will be easy compared to internal medicine and obstetrics or pediatric. The first two or third question, maybe five first questions will be a little hard in internal medicine in the exam, so don't surprise. Now I will start, my plan here is to start in one section like gastroenterology. I will start in this. In gastroenterology, I will speak about general informations about gastroenterology. Then I will enter some slices in Turkish language in gastroenterology. Then in every part I will solve some questions that came in the exams, last exams. So here we have to know how doctors, Turkish doctors, are thinking. What do they love? What do we have to focus on? So my job here is to explain these points and help you to pass this exam easily. Believe me, I will give every information that I can to and I will gather every information to make this easy, inshallah. I passed this exam in August last year. It was not easy at all. They focused on some sections like immunology, so and cancers, so it was a little hard. But some exams, gastroenterology, they love gastroenterology, some exams cardiology, so we'll take everything in this class. So follow me. If you want to reach me, you can follow me in this email. Believe me, you have, if you want to pass this exam, you have to repeat and repeat and repeat. You have to repeat every section 6 to 7 times. You have to study. You have to study very hard. You are doctors. Now, Let's start in gastroenterology. In gastroenterology, as I said, we'll start in general informations in English language, then I will insert some slides in Turkish language. So, in esophagus, excuse me, the majority of diseases of the esophagus result in dysphagia. Dysphagia is the most important symptom for the esophagus. Dysphagia refers to what? To difficulty on swallowing. A few diseases of the esophagus result in pain on swallowing. Pain on swallowing means odynophagia. So we have two symptoms, odynophagia and dysphagia. Dysphagia means difficulty swallowing. Odynophagia means pain on swallowing. Both dysphagia and odynophagia will result in weight loss if the symptoms persist for more than a few days. We know that when we have a case, and in the case mentioned that there is weight loss, then we'll think about cancer. But dysphagia and odynophagia, of course, when these symptoms persist for more than a few days, it will be weight loss. Odynophagia mean, as I said, pain on swallowing, and it refers to inflammation, infection, ulcers, esophagitis. So when we mention that there is odynophagia, then we have inflammation or infection. But dysphagia means obstruction somewhere. This obstruction will be mechanical or neural like achalasia, mechanical like cancer. But we have types for dysphagia. These types are maybe progressive, as example, difficulty in swallowing solid 6 months ago, then to liquid. In this case, we'll think about progressive dysphagia. Progressive dysphagia in general refers to cancer, especially if there is weight loss or general symptoms like anemia, as we'll see. The next step for cancer every time is endoscopy. Dysphagia with systemic symptoms like weight loss, we'll think about cancer again. Scleroderma like thin, shiny skin, we'll think about scleroderma. Scleroderma, we'll study this later in this section for esophagus, and we'll study scleroderma in general in another part. Paradoxical dysphagia. Paradoxical dysphagia when it starts with both liquid and solid. For both, this is paradoxical dysphagia. Now, paradoxical dysphagia with no reflex, no GRD, then it will be achalasia or webs or rings, as we'll see. But if there is paradoxical dysphagia with reflux or GRD, then it will be crest or scleroderma. This is very important information. If in the case said that dysphagia with heartburn, then you will think about scleroderma or crest. When in the case he say that there is just pain on swallowing, dysphagia, not odynophagia, dysphagia, difficulty on swallowing, this dysphagia is paradoxical, intermittent, you will think about achalasia. If he said that this paradoxical dysphagia is stable all of the time, you will think about webs or rings. Stable dysphagia, we'll think about Chatinsky rings or webs. Stable paradoxical webs, intermittent paradoxical achalasia or progressive cancer, paradoxical dysphagia with GRD, scleroderma or crest. Simple, just organize them in your mind. Simple, believe me, it's very, very simple. In exam, he will play with these words. He will say intermittent dysphagia, progressive dysphagia, there is weight loss, there is something, anemia, blah blah blah. Acute with chest pain. If we have dysphagia with chest pain, it will be spasm, diffuse spasm or nutcracker. I will say that a patient that came with heart disease symptoms but ECG is normal, there is no pain, spreading pain for the arm, just behind in the chest, you will think about spasm, diffuse spasm or nutcracker. Now, high dysphagia, we will think about Zinker's diverticulum. Next step in Zinker's is barium, and there is very important information about Zinker that you can't make endoscopy. The contraindication for Zinker's is endoscopy. You can't do endoscopy or NG tube in Zinker's because it will perforate. So we have to know the differential diagnosis in dysphagia, and always the next step will be barium swallow. The next step for after barium swallow will be endoscopy or motility studies by manometry, as we'll see. The presence of dysphagia or odynophagia is not sufficient to help one establish the diagnosis. The basic question is what the additional informations that will be added to the presentation to sufficiently answer the question. In general, barium swallow or barium esophagogram is a good answer to this question. However, if there are clear signs for obstruction, then the answer will be our endoscopy. So, we'll start now with achalasia. 32-year-old woman with no past medical history comes to your office for the evaluation of difficulty swallowing. So, we have dysphagia. She has had this problem for almost a year, and it's most difficult for her to eat solids. Her symptoms have not worsened at all over this time period, so we don't have progressive dysphagia. We have dysphagia that is not progressive, and her weight has been stable. There is no weight loss. Physical examination is unremarkable. What is the next step in evaluation? Now, we said that we have stable dysphagia. Maybe we'll think webs or rings, but woman, 32-year-old with dysphagia, maybe we'll think about achalasia, maybe we'll think about webs and rings, and the barium swallow will show what the answer. Pathogenesis. Achalasia is idiopathic loss of the normal neural structure of the lower esophageal sphincter, LES. The LES in usual, as you know, contracted to prevent the acidic acid content from refluxing backward into the esophagus. For swallowing to occur, when we have swallowing, there is normal relaxation. Now, how the relaxation occurs? Process of the LAS in order to allow food to pass in the stomach. Inhibitory neurons are stimulated to activate relaxation. These inhibitory neurons block the impulse, the continuous impulses that cause the constriction. So we have continuous impulses came from neurons that cause constriction, but when we have swallowing, inhibitory neurons will be stimulated. Now in achalasia, inhibitory neurons have been lost, so it will be continuous impulses for constriction. Now in Turkish language, we'll say about little words about achalasia. So achalasia hastalığı plexus zedillenmesi. We have a damage for the plexus in achalasia disease, hastalığı disease. Alt esophagus sphincter, LES, in the lower esophagus gevşememesi. It will not able to relax. Nedeni oluşur. Manometric çalışma, the working of manometric for esophagus, the lower esophagus will see increase in the passenger in the tension or pressure. Esophageal kısım, in the upper esophageal, we will see dilation. Sometimes we see in achalasia we'll see yutma kuşluğu, difficulty in swallowing, difficulty in swallowing for both solid and liquid. In the CX-ray graphy we'll see yiyecek, food, retention, bağlı, hava, sıvıyı see, and we can see air, liquid level in the CX-ray. Now, the mucosada dysplasia, we can see in the mucus, we see dysplasia in the stage or the next stage. We can see also squamous cell carcinoma, and this is a very important information in achalasia. What the cancer that occurs in achalasia, it will be SSA, not adenocarcinoma. Now, what is the cause for death in achalasia? Is it squamous cell carcinoma? Is it other cause? The cause of death in achalasia will be aspiration pneumonia, not squamous cell carcinoma. This came 2 years ago in the exam. Paradoxical dysphagia, insect symptom. The most frequent symptom for achalasia is paradoxical dysphagia. Dysphagia yavaş gelişir ve genellikle intermittent. In general, it will be intermittent and slowly growth. Intermittent. Dysphagia katı gıdalara artar. It will be slowly and increasing for solids. And sıvıları daha kolay içilir. You can drink liquid more easier. Hastalar yemekten sonra ayağa kalkmak ve hareket etmek ihtiyacı hissederler. Yani the patient after the meal will need for standing or keep moving and not it can't sit down. Hypertonic sphincter, gastroesophageal reflux ordinary yanılma olmaz. Because of the hypertonic sphincter, there is increase in the pressure for the sphincter. Now we have no heartburn, yanma. There is no heartburn. Gece pulmonary aspiration gelişir. In the night we will have pulmonary aspiration. Achalasia'da en sık ölüm nedeni aspiration pneumonia as we mentioned. Achalasia esophagus squamous hücreli karsinoma, squamous cell karsinoma hücreli cell predisposan bir factor. Now, the way to diagnose tanı yöntemleri, the way to diagnose direct grafisi esophagus genişlemesine bağlı. Mediastin'de genişleme. Yani we'll see wide mediastinum and wide esophagus. Aspiration pneumonia signs belirtileri. Signs maybe we'll see the signs of aspiration pneumonia. Bariumlography, the graphy of barium. We'll see in the alt esophagus, in the end of the esophagus, bird beak, kuş gagası. Now, manometric basınç ölçümü, the measurement of the pressure of the LES. This is the most accurate way to diagnose achalasia. Now, this is another STS question. What is the most accurate way to diagnose achalasia? Kesin tanı. Kesin tanı will be manometric studies. So, what are the causes of achalasia? Idiopathic is the most, in the most of cases, will be idiopathic. Now, if we said we have stable or intermittent, not progressive, dysphagia with weight loss, it will maybe weight loss maybe is from achalasia and maybe is from other thing. Cancer may lead to achalasia, so every achalasia with weight loss must do endoscopy and CT scan and other way to confirm that there is no cancer. Chagas disease may lead to achalasia. Chagas disease is the cause is trypanosoma. In Chagas disease we have megacolon, megaheart, and achalasia. Clinical presentation for achalasia, as we mentioned, dysphagia to both solids and liquids, paradoxical. We can have regurgitation several hours after eating. Now, if we have regurgitation for foods from esophagus to mouth, and maybe we'll have food on the pillow after in the morning, we have two differential diagnoses for this case: Zinger's diverticulum or achalasia. This is very important information. Now in achalasia, as we mentioned, we can see weight loss. Achalasia has no relationship with alcohol or tobacco at all. This is different from esophageal cancer, which not only usually present with dysphagia to solid foods that progress to difficulty swallowing liquids, but also is more common in older patients. The age is alarm symptom with a long history of alcohol or tobacco. Now, the diagnosis for achalasia, as we mentioned, the first step is barium study. Barium esophagography is very accurate and shows dilation of the esophagus, upper esophagus, which narrow in birthweeks in the distal end. The golden standard, the most accurate test overall, is esophageal manometry. In manometry, we'll see increased lower esophageal sphincter resting pressure. Now, EGD, esophagogastroduodenoscopy, upper endoscopy, is done for alarm symptoms. What are the alarm symptoms in achalasia or any disease? Age more than 60, anemia or heme-positive stools, more than 6 months duration of symptoms, or we have weight loss. Although a chest X-ray may show an air fluid level, it is not very useful. Treatment for achalasia. The best initial therapy is pneumatic dilation or surgery. Pneumatic dilation should be effective in 80 to 85% of patients, but in this procedure we have 3 to 5 risks of perforation. Botulinum toxin injection into the LES are used in those patients that not willing to undergo pneumatic dilation or in whom it has failed. When the surgery is failed, when we have an elderly patient that can't came to surgery like heart disease or other things, will make botulinum toxin. Also, that botulinum toxin is relatively benign, but there is limiting factor that there is need for additional injections a few months, like every 6 months we have a new injection. Botulinum toxin is also used in patients who are poor surgical candidates, as I said. Example, the elderly with multiple comorbid conditions who would not tolerate surgery. Now, if pneumatic dilation and botulinum toxin injection fail, then surgical myotomy is performed. Myotomy will do the surgery on the LES and have the myotomy will be performed laparoscopy and result in about 20% of patients with complication of therapy is reflux. Now, for medical treatment, we maybe use calcium channel blockers like diltiazem and nitrate. They will give muscle relaxation and decrease the pressure. Now we'll talk about esophageal cancer. 62-year-old man comes for evaluation of progressive difficulty swallowing solids and recently semi-solids for 4 months. So, in 4 months we have progressive dysphagia. He has noticed a 20-pound weight loss. His past medical history is significant for reflux esophagitis for 15 years and 40 back year of smoking history. Now, we have two important things here. Smoking. What is the cancer that occurred from smoking in esophagus? It will be squamous cell carcinoma. But the cancer that came from reflux will be adenocarcinoma after Barrett. So, on the physical examination, we notice that 1.5 centimeter left supraclavicular lymph node is found. The remainder of the physical examination is unremarkable. So, we have progressive dysphagia, weight loss, reflux, smoking, and lymph node. So, he said that there is cancer. Easy question. Now, reflux cause adenocarcinoma, as I said, in lower section of the esophagus. Smoking and alcohol cause squamous cell carcinoma of the upper two-thirds of the esophagus and the proximal. Now, in our patient, the next step will be needle biopsy by EGD, by the upper endoscopy. Excuse me. Clinical presentation for esophageal cancer. Esophageal cancer present with progressive dysphagia. Progressive dysphagia, first for solid food, then for liquids. Weight loss is prominent, as I mentioned. Rarely halitosis. Halitosis means bad breath, regurgitation, and hoarseness. Hypercalcemia may arise, as it can with most cancer. Diagnosis for esophageal cancer is easy by barium swallow, then with endoscopy that is mandatory because this is a diagnosis that requires a tissue biopsy. CT scan for local or far spread. Bronchoscopy detects a symptomatic spread in the bronchi. Now, endoscopic ultrasound. Please focus about this thing. Endoscopic ultrasound in most of the tumors in esophagus or stomach or duodenum or angibar sac or the other GI system, the local spread or staging for tumor is all the time endoscopic ultrasound. Endoscopic ultrasound is the best way to stage the tumor for local spread. This is very important information. Treatment. The only truly effective therapy for esophageal carcinoma is surgery. Unless there is widespread for the esophageal cancer, then we will treat with chemical and radiation. Survival for 5 years is 5%, so it is bad tumor. Now, 63 yaşında bir erkek hasta 10 yıldır süren pirozis ve regurgitation. 63 bir hasta with 10 years with heartburn and regurgitation admitted to the hospital, Başvuruyor. In the history, in the last 3 months, for solid foods, we have difficulty swallowing. Yutarken güçlük. When he swallow, there is difficulty. In the end, last 2 months, he lost 3 kilogram of the weight. Labs 11 for hemoglobin and 33 for hematocrit polymer. 10 days he has shift dose for BBI, and then when the symptoms has got fine, he stopped the medication. So what are the indication of upper gastrointestinal system? Ozone cirrhosis, a lost standing heartburn, inson to either kilocarb weight loss for 2 months, katı gıdalara yutma güçlüğü, difficulty in swallowing solid foods, hematocrit for 32 or hemoglobin for 11, BBIS kesilmekten sonra after stopping BBIS the symptoms has returned. So as we mentioned, weight loss, anemia, progressive dysphagia, katı gıdaları yutarken güçlüğü, difficulty in swallowing for solids then to liquid, it will be carcinoma bulguları, symptoms and signs for carcinoma. For BBIS, there will be no benefit in carcinoma, and the benefit is refers to nothing. Heartburn will mean that we have useless GRD and may be referred to adenocarcinoma after Barrett syndrome after GRD. So A, B, C, D will be right. BBIS refer to nothing. Excuse me. Now, endoscopy indication. Medical tedavi dirençli hastalıklar, resistant for medication, complication, komplikasyon bulgusu olan hastaları, the signs of and complication for these things: gastroesophageal reflux, the reflex in the gastroesophageal. Now, the endoscopy will be not very useful. Değeri düşük. Şu durumlarda yapılır. We will make it in these cases: dysphagia, odynophagia, regurgitation, weight loss, kanama, bleeding, sık kısmaları da, and vomiting, frequent vomiting. Gastroesophageal reflux zamanında Barrett epitelial gelişen hastalarda takip için yapılır. For controlling Barrett syndrome, Barrett esophagitis. Now, 5 yıldan daha uzun süren reflux olan hastalarda önerilmektedir. We'll advise about controlling reflux if the reflux continues for 5 years. Dysphagia, gastrointestinal system kanaması, the bleeding of the upper gastrointestinal, hem tanı için, yani it will have the diagnosis and maybe will treat by endoscopy for upper gastrointestinal bleeding. Alt gastrointestinal bleeding, sometimes the lower gastrointestinal bleeding will be we can't make know the reason for this in 10% of the patients, so we'll make upper gastrointestinal endoscopy. Sebebi bilinmeyen demir eksiliği anemisi, the anemia of iron, for not when we don't know the reason. Gizli kanama, occult bleeding, bağlı demir eksiliği anemisi olabilir. The occult bleeding that will lead to the anemia of iron. Varices, esophagitis, esophageal hernia, atrophic gastritis, ulcers, benign and malignant tumors, vascular pathologies, gizli kanama yapıp anemia neden olabilir. So this is the causes of occult bleeding. Diğer nedenler other causes, foreign body, or when we don't know the cause for bulantı, nausea, and kusmalarda vomiting, then we'll do upper endoscopy. This slide is very important when to do upper endoscopy in like lower gastrointestinal bleeding, when we don't have the reason, when to endoscopy and reflux, when we have daha uzun 5 yıldan daha uzun süren reflux, we have to do endoscopy, or when we have this durumlarda dysphagia, odynophagia, regurgitation, blah blah blah. So you must focus in this slice. Scleroderma. Now, progressive systemic sclerosis and CREST syndrome that will be limited scleroderma. We'll study scleroderma and CREST more in other section, but here we'll study the esophageal symptoms in scleroderma and CREST syndrome. 80 to 90% of patients with scleroderma will develop diminished esophageal peristalsis from the atrophy and fibrosis. Of course, in esophagus we will have atrophy and fibrosis, and it will lead to useless tube esophagus. Less tube esophagus, and it will lost the smooth muscles. Then it will lead to, of course, thin shiny skin for the scleroderma, and it will lead dysphagia because of fibrosis. There will difficulty of swallowing, and the main clue to the diagnosis is simply the presence of gastroesophageal reflux symptoms. GRD is the most important symptoms in the scleroderma. The LAS will neither contract nor relax. So we'll have GRD and dysphagia because the LAS will neither contract nor relax, and basically assumes the role of an immobile open tube. So scleroderma esophagus tutilmo, as I said, it will be in scleroderma, the esophagus will be damaged in 80 to 90% in patients. Scleroderma da orta ve alt esophagus tutilmo, the median and lower esophagus will be damaged. Thus, gastrus smooth muscles function kaybı will be lost ve motility clear. This motility, some you will notice that some words in English came but will be a little dysmotility. Buna bağlı klinikte gastroesophageal reflux, esophagitis, dysphagitis, regurgitation meydana gelir. We'll see dysphagia and reflux. Reflux may be to esophagitis. Dudaklar, the lips will be thin, ince, and büzüşür ve ağız açıklığı azal. The patient can't open the mouth. In ileri evlerde, in the next steps in the disease, parmak uçlarında, in the end of the fingers ve proximal interphalangeal eklemleri, in the joints of the interphalangeal dorsal yüzlerinde zor kapanan, it will be difficult to close the fingers because of the thin skin on the dorsal face, and it will be painful ulceration. Painful, not painless. This is important. CTC exam. Painful ulceration, not painless ulceration. It came in the CTC exam. Ağırsız ulceration. Ağırsız wrong. Ağırlı ulceration. Ulceration. So, cilt altı classification. We'll see classification in under the skin that will cause the ulcers. Hastalığın geç dönemlerinde when in the end stage of the disease deri yumuşamaya başlar ve atrofik bir hale alır. We'll see atrophic and of the skin. İç organ tutulma olarak the organs that will be affected in the disease will be GIS, lungs, kidney and the heart. GIS'de en sık tutulma yeri esophagus. The most frequent to damage in the GIS is esophagus. Esophagus kaslarının hypocontractility in the muscles of the esophagus there will be hypocontraction. The alt esophagus sphincter LAS will be relaxed, LA characterized. The most specific sign will be geoishmi, wide or relaxed. Sclerodermal olgularda esophagus hypocontractility ortaya çıkar. There will be hypocontraction in the esophagus as I mentioned. Because of the fibrosis. Diagnosis, the most accurate diagnosis is motility study. We'll see manometry, that is the golden standard. The treatment, BBIS, such as isomeprazole for the reflux, metoclopramide for to make the LAS more useful. Now, diffuse esophageal spasm and nutcracker esophagus. 34-year-old man complains of crushing chest discomfort, like heart diseases, for 1 hour. He has no significant medical history. The ECG is normal. He is given sublingual nitroglycerin in the emergency room and improves his chest pain almost immediately. Almost immediately. This case came 2 years ago, and it was like this: chest pain, ECG normal in young patient. He mentioned that he has episodes of neurosis or psychosis, just like that, and he mentioned nothing else. So, neurosis or young patient with chest discomfort with ECG normal, immediately we think about diffuse esophageal spasm. When he says that the patient improves for nitroglycerin, it will be spasm. Next step, motility disorder. For this motility disorder is barium. As I mentioned, every dysphagia will be barium, but here there is a very important information. Outside the attack, the barium swallow will be normal. The barium swallow in the attack will be significant and specific, but if the patient has no signs or symptoms, barium swallow will be normal, so it will be useless out of the attack. And the kissing tunnel, the accurate test will be manometry. So this is barium study in the attack. It is very specific, but out the attack the barium study will be normal, and the golden standard is manometric. Manometric will be specific and will give information in the attack and out of the attack. So clinical presentation: intermittent chest pain, dysphagia without effort. The most important thing is without effort, to distinguish with heart diseases. No relationship with exertion, no relationship with eating, ruling out Odynophagia. Odynophagia is pain on swallowing. Here we have no swallowing. Pain came without swallowing food, except for one thing: cold liquids. When we mentioned that the patient took cold liquids, then the chest pain occurred, then we think about esophageal spasm. Treatment: calcium channel blockers such as nifedipine and nitrite will be immediate relief. In the attack, nitrate. Now the treatment will be just in attacks. There is no need for continuous treatment. So in spasm we'll focus about golden standard is manometric, and in the attack barium study. The first step out of when there is no attack, manometric is specific, barium will be normal. Rings and whips. So as I mentioned, intermittent dysphagia and is not associated with pain. Achalasia is intermittent, but sometimes whips and rings may be intermittent, but in general stable mean rings and whips. Intermittent means achalasia, but achalasia and whips sometimes comes intermittent and stable. So the complete of the case will distinguish between rings and whips. Now in Shattuck rings, more distal and located of the squamoclumnar junction, proximal to the LES. So Shattuck ring will be in the lower esophageal. We see it more in men. Pulmonary Vincent syndrome, more in women. Anemia, more proximal and located of the hypopharynx, upper esophagus. So Plummer Vinson webs will be in the upper esophagus and in women and with anemia, but Shattuck ring in the lower esophagus and at the squamoclumnar junction and in men. Plummer-Vinson syndrome, sometimes there is relationship between Plummer-Vinson syndrome and squamous cell carcinoma, but rings may be adenocarcinoma because it is lower in the lower esophagus. Diagnosis. Both disorders are best diagnosed with a barium swallow or barium esophagogram. After endoscopy, the symptoms may relieve a few days. This is very important information. Patient with intermittent or stable dysphagia came for your polyclinic and you made endoscopy. After the endoscopy, the patient feels that he is okay. This will be webs or rings. Treatment. Plummer-Vinson syndrome may respond to treatment for iron deficiency. Both are treated with dilation procedures. Now, Zinger diverticulum. 25-year-old medical student comes to seek your help because he thinks he had bad breath, halitosis. This past weekend, a most disturbing event occurred while he was watching a football game. He coughed up the chicken he has ate 2 days earlier. He claims to brush his teeth every night. The physical examination is normal. The next step will be. So, young patient with bad breath, with coughing, old food, but he didn't mention anything about dysphagia or other things that related to achalasia. So it will be Zinger diverticulum. Halitosis, coughing, old food, as I mentioned, Zinger or achalasia. But if he mentioned halitosis with coughing, old food, he means Zinger, not achalasia. Achalasia, he will give another information. So, esophageal sphincter dysfunction, upper esophageal sphincter dysfunction, Zinger diverticulum. Alt esophageal sphincter dysfunction, it will be epiphrenic diverticule. So in upper esophageal sphincter will be Zinger, in the lower esophageal sphincter the diverticle we call epiphrenic. Epiphrenic diverticular insects will be achalasia. Achalasia is the frequent cause of epiphrenic diverticle. فقط esophagus diverticular and then insect Zinger, but the most frequent diverticular for in the esophagus is Zinger. Now, esophagus cricopharyngeal Bolgeden Kuchen Aller. It will happen in the cricopharyngeal space or place. Pulsation diverticular. It is pulsation diverticular. The most important complication for Zinger diverticular is diverticulate, the inflammation of the diverticulum, or malignancy. The malignancy will be squamous cell carcinoma. Squamous cell carcinoma. تداوي diverticulotomy. The treatment is surgery, will be diverticulotomy. And for diagnosis we will do bariography, not endoscopy or NG-tube. So in Zinger, the first step will be barium. The important contraindication is endoscopy or NG-tube. Zinger diverticulum is the outpoking of the posterior pharyngeal constrictor muscle at the back of the pharynx. Now, we'll make some cases, fast cases. 53-year-old man came with intermittent dysphagia. AGD was normal. The dysphagia started with liquid. Next step. Now the patient has dysphagia, is not stable, so it's not maybe achalasia, because achalasia will be intermittent. There is no chest pain, so it's not spasm. Man suggests Shatisky web, and the next step is barium. I repeat, intermittent and stable dysphagia, sometimes he will mention that achalasia will be intermittent and stable, webs will be intermittent and stable, but in general when he gave us just intermittent or stable, intermittent will be achalasia. Intermittent will be achalasia. But here AGD was normal. In achalasia, AGD will see narrow in LES. Now, esophagitis. In general, in CTC, he will not focus on intermittent or stable a lot. He will give us another informations like EGD or something else, as we'll see in a question that will come. Now, esophagitis, the main symptoms is Odynophagia, as I mentioned. Esophagitis refers to either infection or inflammation of the esophagus. The most common infection is from Candida albicans. When Candida esophagitis occurs, it is almost exclusively in patient who has HIV. Now, diabetes mellitus is the second most common risk for developing Candida. So, Odynophagia means esophagitis. Esophagitis means that the most common cause is infection. The most common cause of infection is Candida. Candida, the most common cause for Candida is HIV. The second will be diabetes. Now we have, excuse me, we have other etiology of esophagitis like herpes simplex, CMV, and other causes. Now, medications may be cause esophagitis. The most important medication is alendronate and other bisphosphonates. Now, peptic esophagitis in 6 baby gastroesophageal reflux. The most frequent cause of the esophagitis, the peptic esophagitis, is reflux. Bundan nedeni limirbanın gevşememe ve esophagusun kardiyasının açısını sağlamaya. So, the reason for this is that the lemur ligament is loosened and the esophagus cannot provide the angle of the card. Kesin tanı için endoscopy ve biopsy. The definitive diagnosis is endoscopy and biopsy. Ayrıca, in addition, peptic esophagitis pH monitorization tanısı koydurabilir. We can make diagnosis by monitorization of pH. If the pH is under 4, the diagnosis will be, we can make the diagnosis. But pH monitorization, endoscopy ve biopsy kadar değerli değil. It will be not valuable as endoscopy and biopsy for esophagitis. Now, peptic esophagite önemli complication is adenocarcinoma. The most major complication of peptic esophagitis is the developing of adenocarcinoma from parotid esophagite. Clinical presentation. Now, progressive odynophagia will refer to infection or inflammation, yani esophagitis. Also, the swallowing is painful. Food is still able to pass until the disease is extremely advanced. With that, there is no dysphagia until severe cases. So, in esophagitis, we have odynophagia without dysphagia. The major difference between the pain of esophagitis and the pain of spastic disorder, as I said, that the esophagitis, the pain is only on swallowing. When there is no swallowing, there is no pain. Whereas the spastic disorder, the pain occurs intermittently without needing to swallow, without exertion, maybe with neurosis. Esophagitis pain is simply from the mechanical rubbing of food against an inflamed esophagus as it passed by. If the patient is HIV positive, the diagnosis is confirmed simply by seeing the response to empiric treatment of fluconazole. If the fluconazole doesn't work, then endoscopy should be performed. Now, because esophagitis can also result from ingestion of medications and caustic substances like alendronate or other, the direct effect of contact between the mucosa and the pill causes this inflammation. Rather than infection, we don't have infection, just inflammation. The diagnosis is based on the presentation and findings that the toxin in the history. The most common pills that cause esophagitis: alendronate, quinine, risendronate, vitamin C, potassium chloride, doxycycline. Doxycycline came 2-3 years ago in STS exam. Doxycycline will with Odynophagia, NSAIDs and iron sulfate. Pill esophagitis is managed by simply swallowing pills in the upright position and drinking enough water to flush them into the stomach. Consider pill esophagitis in a young patient who is taking medication for acne, doxycycline. The case that came was a young patient that taking doxycycline for acne, and he got Odynophagia, the acute onset of Odynophagia. Now, for now, I will give every day an hour. I hope that you have a little benefit from my class for this hour. I hope I give the right information for CTC, but believe me, I worked very hard for these informations. I gathered them from many books and organized them to be simple as I can. Now, I will complete tomorrow for another hour. We'll complete with esophagus and for the stomach. Now, good evening and kendinizi iyi bakın. Good night.